Hello and happy Friday and welcome back to From Belly to Baby. We had 1 week off. We're back. It's hot outside. No one wants to be outside, so we hope you are enjoying your Friday in front of the computer right now. I'm Abby. I am 31 weeks pregnant. I keep trying to give myself a bonus week in there, but every doctor I talk to is like, you don't want to do that now. Don't start. And I'm visiting today with a neonatologist from St. Louis Children's Hospital and Washington University, Dr. Emily Fishman. So thanks so much for joining us.
Yeah, thanks. Happy to be here.
And we are going to, first of all, we're going to be talking in this hour a little bit about, or a lot about, what happens to baby in that first, let's say, hours, days of life, because there is a whole big checklist you all go through. But before we get to that, I want to tell people a little bit about what you do, because you wear many hats. As I mentioned, you're a neonatologist at Children's. Today we are at Missouri Baptist Hospital, where you also attend. Tell us a little bit about what you do when it comes to labor and delivery.
Sure, exactly. So part of our role on labor and delivery, depending on the hospital that we're at, we're often asked to attend high-risk deliveries. So that can be anything from under 37 weeks gestation, anytime there is a concern about the baby or a concern about the mother, and really anytime anybody has any concerns, a pediatrician or a neonatologist will be present at the delivery, especially at the hospitals that we attend at.
Gotcha. And so you attend both here and then at Barnes Jewish Hospital on the main campus, and then you take care of the babies in the NICU as well.
Yes.
So you see a whole lot of babies.
Yes.
So she is very well experienced and can run down this insane list that I have made, and I have officially hit the list making point because I don't remember anything for more than 5 seconds now. So I promise not to be reading off of this, but I did want to make sure that we covered a whole lot of ground. And if you have questions as we're going along, please feel free to chime in. Dr. Fishman is here to help answer as much as we can. And if there are questions that we can't answer in this hour, we'll certainly point you toward the resources afterwards. So just punch those into the comments. And as we get started, we'll ask you a couple of times along the way. Let us know, expectant moms out there, how far along you are in this journey, and if you have any random words of advice, let's say, for other expectant moms out there. I know, Dr. Fishman, you just went through this yourself. Mm-hmm. You have a little one.
I do. So it's been very recent, and it's quite the journey to go through the pregnancy, delivery, and then even the immediate few months afterwards.
We were just commiserating about swollen feet and the joys of compression socks. So we'll leave it at that. They're great, but boy, it's an adventure, this whole thing. So let's get right to the delivery room. So once mom goes into labor and you've got a baby on the way, at what point do you come into the delivery room?
Exactly. So a OB or a nurse may ask us to come and speak to a mom ahead of time if we think that the baby may need some extra support after they're born. Otherwise, usually the nurse will call us when they're ready to have a baby.
All right. And so baby's out. First thing you always think about with the baby's arrival is somebody's going to cut the cord. But there has been a lot of discussion lately about something called delayed cord clamping, correct? Am I saying that correctly?
Yeah.
All right. Can you tell us a little bit about what that is and what it means?
Sure, exactly. So the cord is a great source of hemoglobin and iron that can be provided to the baby. A lot of research has shown, especially for our preterm babies, that it can increase their hemoglobin and increase their iron stores because the third trimester is when you really get the bulk of your iron stores. So those babies, especially the preterm babies, it has shown to decrease the risk of anemia, needing blood transfusions, or even potential serious infections. So we universally do it for at least our under 34 weeks gestation, and then some OBs, based off of their practices, have been doing it past 34 weeks and up to term.
I'm sorry, is that something you should ask your OB about, or is it standard per hospital? Who makes the determination?
Sure, I would say it's a OB to OB provider preference. A lot of hospitals are doing the practice. What an OB may think about in making that decision of whether or not a baby is a candidate for it is how they're doing after they're born. They will examine the baby, often feel for a heart rate, which you actually can feel for a heart rate through the umbilical cord. And warm and dry the baby as well. And if the baby is looking vigorous.
All before the cord is cut?
Mm-hmm.
Well, I'll be darned. I did not know this how it happened so quickly. Okay, go on.
Yes. So the OB will assess the baby, and if the baby is vigorous and moving around and will kind of warm and dry with a towel, we'll wait up to about a minute or two to do the delayed cord clamping.
Okay, so a delay, we're not talking like even minutes or hours. It's just about a minute.
Yes. Usually that's been our standard of care. It's been about 60 seconds.
Okay. And related also to the umbilical cord, we hear a lot about cord blood and cord blood banking. And I remember from my first prenatal appointment, my doctor talking a little bit about it. Now that we're getting closer, it's something that I feel like is probably worthy of a little more consideration. Can you talk a little bit about cord blood banking and the difference between private and public options?
Sure. So that's usually cord blood banking is something you need to think about and discuss with your partner prior to delivery, because there are two options. There's private and there's public. Private cord blood banking does take a little bit more work on your part. That usually requires a little bit of research, and it does usually come with an annual cost as well as an upfront charge. A lot of advantages and thoughts behind it is that cord blood gets stored away for you specifically should you or a family member need it down the road.
And for what purpose would you need it down the road?
That's a good question. A lot of research and thought is it can be used potentially for a stem cell transplant should you or a family member have something serious like leukemias or lymphomas.
Okay. And then from the public aspect of it, it goes into a publicly available bank for the same purpose, but anyone can access it, and it's free, correct?
Correct.
Okay.
So public cord banking is not offered at every hospital, but is offered at many hospitals. You don't necessarily have to enroll usually before you come into labor. It's something that you can discuss with your nurse when you are getting admitted. And then it just goes to a public cord bank, meaning that you are not going to be able to specifically obtain that blood specimen back. It's kind of a donation. But the thought process is those stem cells will go on to for further research and for further help with other babies or children or even adults.
All right, so we've talked umbilical cord. Baby's out. At this point, let's say cord is cut, go 90 seconds in. What happens next? I know it's a little bit different from hospital to hospital, but does baby go immediately to mom, immediately to the bath? What happens?
Sure, exactly. So it really depends on how the baby is doing. If the baby is crying and is vigorous, is moving around, our first goal is to always put them baby skin to skin on mom. Especially in a vaginal delivery. In a C-section, it can be a little bit more challenging. It's not completely unheard of. Sometimes the baby will come to the warmer and then go to mom just for logistics. But otherwise, our goal in a vigorous baby is to go skin to skin, and then we will assess the baby on the mom's chest.
So right up here, that's where you're doing the checkup?
Yep.
And what's the purpose of that?
So it's a huge part of that bonding experience between mom and baby is one part. Another part is it really helps promote breastfeeding. Another part is it helps with temperature regulation. And another part helps with blood glucose monitoring and blood glucose control. So it really has lots of benefits to mom. So even if it can't go
to mom, even interesting.
Helps with breast milk supply, and so it's really a two-way street between mom and baby.
I hadn't considered that. I just assumed that was all to help the baby, but and I guess if you think about it for more than 5 seconds, it makes a lot of sense. I mean, that's a huge transition to be going from, carrying a baby to having it on the outside, and that's a heck of a transition for baby to go from the confines of the womb out into the world. So I guess anything to make that a more comfortable, less dramatic experience is probably a good idea. And so with the skin to skin, does baby go right on? In the movies you always see these fresh, clean, probably 3-month-old babies that are being put on mom. Is that the practice? I've heard also that babies aren't bathed right away. And so you just put them on there with it's vernix. I don't know. I'm trying to be as mature as possible when I say this. I understand that it's appropriate to say, it's vernix, right? But it's a goo. It's a white film. Okay.
Yep. So the baby may be a little bit messy, may a little bit of blood after the delivery, may even have a little bit of pee, a little bit of poop. It happens.
It might be the first time Peter pooped on as a parent, but it won't be the last.
It's kind of a time where the parents you're so overwhelmed at the birth of your child, you really don't think about those types of things. It's your child. It's a moment that you will never forget. pee and poop we try to wipe off. The vernix we keep there, and it has a lot of beneficial properties. So it is shedded skin cells that kind of helps coat the skin, and it's a good antibacterial barrier, and we keep it there for 8 to 24 hours, and we wait that 8 to 24 hours before we even do a first bath.
Really? And so in that 8 to 24 hours, do you wipe the skin like on the face or anything like that, or is it just completely left alone?
We'll do like a general drying to make sure the baby is not wet, but otherwise we wait until the first bath to do a real good scrub of the hair and the body.
And who does the first bath?
So that's a good question, depending on how the baby is doing. Most of the times the parents are given that option to do the first bath, otherwise one of the nurses or technicians are available as well.
Gotcha. And do we have a question?
We do. So Jennifer wants to know the thought behind only waiting a minute to clamp the cord. She said the World Health Organization recommends waiting until the cord stops pulsating or after about 3 minutes.
So that's a really good question. I think our standard practice in discussion with our OB doctors has been that's been an ongoing discussion of whether or not even just 2 minutes, kind of a compromise between those periods of time. It's really up to debate. We have shown that the premature babies are the ones that benefit the most from delayed cord clamping. And the reason why we limit it more to that 1 minute period of time is those are the babies that are at higher risk for needing breathing support. And those are the babies that may benefit from coming over to our assessment table sooner. So I think that's the reason why we lean towards that 1 minute. I think the longer time period is probably more easily to be done in the older or the bigger babies closer to their due date. I think we haven't decided in our practice that that would be the standard of care at this time.
Gotcha. So it is amazing how much we're still learning and continue to learn about those first few minutes of life. And we have another question?
Yeah, so Brittany wants to say hi and wants to know how long you've been here because she had twins in the NICU in 2012 and said you look very familiar.
Thanks, I actually have been here for several
We've been tormenting you for a long time.
I have. Well, hi, Brittany. It's good to see you again.
So funny. Brittany, I hope your twins are doing well. If they are, please let us know. Or either way, just let us know. So we've got skin to skin. Breastfeeding was another comment that you had made. So is it, does the baby go straight to the breast at that point if you've decided that you want to breastfeed, or what's the standard of care there?
Yeah, usually it's within those first few minutes, the first 15 minutes of life. It's the goal is to get the baby directly to breast. Now that first attempt may not be completely successful, but it's that skin to skin really helps promote the colostrum from coming in and for initiating that initial latch.
It's so interesting. I was talking to a friend of mine this weekend that I hadn't seen in a long time. We were at a wedding, and she had an emergency C-section ultimately at 36 weeks. But healthy baby and everything was fine, but that was what she was talking about, which she said the most fascinating thing was when they put him on my chest, he immediately started to nurse. It was like he knew what he was doing. So good to know that that's an option, and anything to, I think, and we're going to do a show exclusively dedicated to breastfeeding in a couple of weeks here. I think anything to make that process easier for mom and baby is definitely worthwhile. And along those lines, when you're talking about breastfeeding and habits that are going to be developed early, pacifiers, is that something you need to determine? Is it something you determine you want for your baby beforehand and tell the staff, or does the baby decide? I mean, do the nurses decide? Who makes that conclusion?
Sure, it's usually a discussion based off the parents' preferences. A lot of times we do recommend waiting, at least for the first few weeks for breastfed babies, to avoid pacifiers to help improve a baby latching onto the mom and not necessarily working on sucking on a pacifier. Usually after breastfeeding is well established, then it's pretty good to initiate a pacifier use. That being said, anytime a baby has any painful procedure, potentially, we usually do blood work on all babies in the state of Missouri at 24 hours of age. They may get a pacifier for short procedures just to help them with soothing during that period of time.
Interesting. Oh my gosh. Well, I feel like I should be taking notes on some of these things, but I'm just going to go back and watch later and take notes. So you mentioned the blood work 24 hours later. Let's talk a little bit about some of the procedural things that happen. And I'll let you just kind of give a chronological, or however you want to do it, account of what happens to the baby in terms of shots and tests that will be done in those first 24, 48 hours?
Sure. There's actually a lot that gets done on the baby while they're admitted to the hospital. So the first thing that a baby will have is usually within the first hour of life, after the baby has had time to bond with mom, go to skin, and a first feed. A baby will come over to the assessment table, have weight done, length, how big their head is, potentially may need a blood sugar check, depending if they're on the small side or on the big side. Those are babies that are at higher risk for having low blood sugars. And then we'll administer some medications. So one medication is erythromycin eye ointment. It is to prevent and kind of serve as a prophylaxis for serious eye infections that actually have been shown to cause blindness. So while the actual rate of that infection is extremely rare, we kind of credit that to the fact that we've instituted this widespread eye ointment practice.
And is that just for vaginal deliveries, or does that apply to C-sections as well?
It applies to all babies. All babies.
And is this is it an organism that they would encounter in utero, or just upon exposure, or when does that occur?
The thought process is that eye infection happens as they're passing either through the vaginal canal. That being said, those that are having a C-section, if you have that rupture of membranes, the thought process is those bacteria can be present there as well. So it's a very rare infection, but the thought process is it's a very pretty benign drug, and the fact that it can prevent blindness is pretty helpful.
Sure, yeah. So we've got the erythromycin, and then what else does baby get right away?
The next one that gets little people a little bit uncomfortable is the vitamin K shot. So vitamin K is really important. So at birth, babies have really low levels of vitamin K. It will take several days to even months for them to get more normal levels of vitamin K. And it's really the first week of life where they're the highest risk of bleeding. Vitamin K is used to clot blood. So as you can imagine, if you have low vitamin K, you can have a problem clotting blood, and you can have potential serious bleeding. And what we will see sometimes in babies that don't receive their vitamin K shot, especially within the first few days of life, they can get serious bleeds, including brain bleeds, that can be pretty devastating. So it's a pretty benign administration. It's a vitamin that we all have in our bodies. We use a preservative-free version. It has some things mixed in it, but nothing that's associated with anything serious. It has been shown to not cause serious illnesses, not cause cancer. Those are a lot of the things that people get really concerned about. So it's really essential.
That's really interesting, because it's one of those vitamins that honestly you don't hear a whole lot about, and we all hear about vitamin C or E and D, but vitamin K was one when you said it was a blood clotting agent. I hadn't ever considered what it was for, so that makes a lot of sense.
And it's especially important for breastfed babies. Formula does have enough vitamin K that those babies usually do very well, but breast milk itself actually is extremely low in vitamin K. So it's most important for those breastfed babies to get their vitamin K shot after they're born.
And is it a heel stick, or where does that shot go usually?
Usually goes in the big muscle in the thigh.
In the big muscle in the thigh, which we all know where that is. Good to know. All right, so we've got eye gel and vitamin K. Any other shots?
So the other shot usually babies get in their newborn period is the hepatitis B shot. Hepatitis B is an infection that can be caused, it's a blood infection, can be caused through any type of secretions. At least everybody in the healthcare field has to be immune to hepatitis B, and usually by that is with the immunization series, and it's several shots in a row. And we usually initiate that within the first 24, 48 hours before discharge.
Okay. So going down the list again, we've got vitamin K, erythromycin, hepatitis, and there's also one test that's gotten a lot of attention in the last, gosh, I don't know if it's been a couple of years that legislation made the pulse oximetry test more common among infants, or at least standard protocol. What is the pulse oximetry test? It's not a stick, correct? It's just a check.
So it's actually a really easy check. It came about several years ago, and it's becoming state by state dependent. And our law here in Missouri stemmed from a little girl who presented after several days of life with a critical congenital heart disease. And the thought process is if she had had this type of pulse oximetry monitoring, it may have been picked up sooner. So it is done after 24 hours of life. What the nurse will do is she'll put a pulse oximeter probe on her hand and a pulse oximeter probe on the leg or one of the other extremities, and it's usually the right hand. And we look for what those numbers are, and we look to see if there's a difference between them. We kind of have a standard algorithm that if it is too low or if there's a big difference between them, we'll repeat the test once or twice per the algorithm, and potentially if we need to, we'll get a heart ultrasound. And it's actually been shown to be very helpful and does pick up very sensitive tests to pick up critical congenital heart disease.
It's really an amazing change that we've seen in the last couple of years, and I wish I had checked the numbers, because I know that's something we have at St. Louis Children's Hospitals. We have on file the number of children who we've been able to detect anomalies with because of the pulse oximetry test, and who've been able to get the help that they critically need that maybe they wouldn't necessarily have been evaluated for otherwise.
Mm-hmm.
So we've got pulse oximetry, a series of shots, and you said, was it 24 hours later you have standard blood work?
So after 24 hours of life, we do the newborn state screening, also known, it's kind of known as the PKU if you're a little bit on the older side. And it's a test for a multitude of different diseases. It first was initiated to pick up PKU, or phenylketonuria. It's kind of a mouthful.
Common spelling.
Yes. A mouthful, because that was actually a treatable disease if you avoid certain agents. And as over the years, it picks up some such things as congenital hypothyroidism, sickle cell disease, some of the more severe metabolic disorders. It also will potentially can pick up cystic fibrosis. So it's actually an opt-out in the fact that all babies born in the state of Missouri will get it unless you were to specify that you did not want your child screened. And it is a heel stick. It's a very small amount of blood. It's a blood spot test, and it's pretty impressive the testing they're able to do on these blood spots.
It is amazing the amount of information they're able to garner. And the other question I meant to ask earlier, I just made a note for myself so that I don't forget it. We hear so much about, I think it's APGAR, APGAR scores. Am I saying that correctly?
Yeah.
What is that, and what point is it tested? Is it multiple times along the way, or is it just a one shot right out the gate?
So we look at it at 1 minute of life, 5 minutes of life, 10 minutes of life, and then every 5 minutes to 20 minutes of life if needed.
Okay.
The most common ones are just the 1 and the 5 minutes. It's looking at 5 different components. It looks at heart rate, baby's tone, baby's grimace and how well they're reflexing to your exam or reflexing to the OB's exam, their color, and how well they're breathing. And it's a score of 0, 1, and 2, with the worst score being a 0 and the best score being 10 for all 5 components.
Okay. And so depending on that score, you just evaluate for various other issues that you might need to be attentive to?
Yes, it just gives us a little bit more idea of how well the baby's doing.
Okay.
So.
Right. Are there other decisions that you advise parents to make in advance of delivery?
Yeah, there's a lot of things parents should start thinking in the 3rd trimester. I think the most important one is finding a pediatrician or a family care practice person that would work for you and your family. It's kind of important to identify that person before delivery, just so that you have it all set up. That's one less thing to have to worry about, because there may be an indication for you to see them pretty soon after you go home. Sometimes if we're sending a baby home that may need to be monitored closely for jaundice, all babies have some degree of jaundice. Some may need a little bit more intervention, but those babies, we have them follow up with their pediatrician or family care doctor pretty quickly after they go home from the hospital.
Gotcha. And also, I knew that there are some pediatricians who come into the hospital and check on their patients themselves, so they get a call right away, and so that's just a decision to have made hopefully beforehand. And if you need any help with that, we did an episode entirely about picking a pediatrician. We can link in the comments to this later. But it's really helpful information and resources and places you can go to find names if you just don't know where to start. So that information is out there. And then other decisions as far as what's going to happen to baby in those first few days in the hospital that mom and dad need to make in advance.
So those are things to think about. One is going to be feeding preference, talking
Mm-hmm.
about breastfeeding, any other types of procedures. Potentially, if you're expecting a boy and having a boy, you may want to decide whether or not you would like to have your son circumcised. That's a decision up to you and your partner and your family practices. Often that times that's performed by the obstetrician or the pediatrician prior to discharge home.
Okay, so have that in mind. And then there is also the advice out there from the American Academy of Pediatrics that baby sleeps in the room with mom and dad for, up to a year now?
I think
or
they've
6
actually
months?
changed it to, it was initially 6 months of age, and now they're even recommending up to 12 months of age.
And does that start immediately, or is there an option for baby to sleep in the nursery that first couple of nights? I mean, how should parents go about determining that, or is it just hospital-based?
A lot of that is hospital-based. I think regardless, safe sleep recommendations are going to be important, and that starts even from day one in the hospital, back to sleep, nothing else in the crib, having a good swaddle on the baby.
Mm-hmm.
There usually is the option of potentially even having small breaks with the baby going to the nursery, and that's hospital-dependent. And then the same thing translates when you go home, back to sleep, nothing in the crib or bassinet, as long as it's a nice firm surface for the baby.
And in 2 weeks, I think it is, if I recall the schedule correctly, we'll be talking a great deal more about safe sleep practices and best practices at home. So we'll get into that later, and remind you right now, if you have any questions, please let us know. But in the meantime, I think that really covers, I'm quickly scrolling down my list here, but I think that covers pretty much everything. So do you recommend that parents have, if they have strong reactions to any of these, I don't want to call them options or practices, I guess. Is it something to bring up with the obstetrician now or the pediatrician? How do you go about addressing that and just getting more information? Say, as you mentioned, some people have a discomfort level with the vitamin K shot. Is that something that your obstetrician can help you understand more fully, or who would be the best resource?
I think it would be both. I think having that discussion with your obstetrician before you deliver is very important. They're just as skilled in talking to you about the education and the research behind vitamin K. Should you have any questions about vitamin K after your baby is delivered, one of our pediatricians or neonatologists are happy to discuss that as well. Our hospitals always have pediatricians in the hospital that are always willing to stop by and chat with you as well.
And it is incredible the number of resources that are available in the hospital, the number of lactation consultants and pediatricians and people who can help you better understand, because those first 24 hours, while I'm sure overwhelming to baby, are really overwhelming to mom and dad as well. So it makes a lot of, makes everyone breathe a little bit easier knowing there are experts on hand to help with all of that. Thank you so much for being one of them and for being here with us, Dr. Emily Fishman with the Women and Infants Program and the Newborn ICU at St. Louis Children's Hospital, Barnes Jewish Hospital, and Washington University, as well as today Missouri Baptist. And thank you all. We've got everybody in there. My gosh, you have to travel a long way. Thank you so much for joining us. If you have any questions, if you're following up and watching this show later and have any questions that you would like addressed regarding this topic, please feel free to punch them into the comments, and we'll do our best to answer those. Until next week, we'll be back to talk about packing the hospital bag. So tune in then. We'll be here next Friday at 1 o'clock. Thanks so much and have a great weekend.